now and just let everybody know we are recording this session. Enjoy.
Right. So hi, everyone. We'll get started in just a few moments, letting others join into the session today before we get started. And once again, as Warner just mentioned, the session is being recorded, and we'll go through that in the announcements in a second. If you're just joining, we're going to get started in just a few moments, just letting others get into the session before we start. All right, hello and welcome everyone to the 2021 UNC Water and Health Conference. Thank you for joining today's verbal session on monitoring and evaluation. I'm Timothy Purvis. I work here at the Water Institute at UNC, and I am your room host for today. So before we get started with our presentations, we have a couple of announcements. Our first announcement is that we have a networking event from our sponsor, Remo. They'll be happening today at 3:30 p.m. Eastern Time. And so you can join that through the Pathful platform, which you use to join this session by going to agenda, all agenda items, and then selecting that event from today's options. Additionally, we have the late early show, which if you weren't able to join today's session, it's a great recap of what has happened in today's plenary sessions. They'll be happening tomorrow at 3 a.m. Eastern Time, so that anyone globally can also join and kind of catch up on what has happened in the plenary sessions from today. And so Fere Tunhuma and Tina Tanathegoda will be talking about the lessons learned from today's plenary sessions and how we can use those in an African context. Additionally, some technical instructions for anyone who's joining. We have this session recorded so that anyone who is not able to join the session live is able to watch the recording, or if you are wanting to look back at what was said in any of the sessions, you're able to watch the recordings if you're possibly missing a session. And so with that, we have everyone on this platform muted except for our speakers today to help in that recording process. Similarly, so that we can keep track of questions being asked, we've disabled the Zoom chat, and so all of the chat will need to go through the Pathable page, which you use to join this session. And so you can navigate to the chat and ask questions during our speakers' presentations that they will then answer in a Q&A session after each presentation. Additionally, our speakers have uploaded their presentations and any relevant files into this Files tab that you can find right next to the chat session, or chat tab. Lastly, we need to thank our sponsors for today. So we would like to thank Biorad and Reckitt Global Hygiene Institute for making today's session possible and for allowing great work at this conference. So we have 3 great presentations today, and the order that we'll be going through is actually David Berendez from the CDC, then Christine Marie George from Johns Hopkins, and then Rick Johnson with the WHO UNICEF Joint Monitoring Program. And so, David, that is it from me. If you would like to begin, I will stop share. If you want to share your screen, you have 10 minutes.
All right. Thank you very much. Hopefully you can all see and hear me well. I'm David Berendez from the CDC, and I'm here to talk to you about sustainability of a local production of alcohol-based hand rub, or ABHR, project in Uganda that my team has worked on over the last 3 years in Kabarole district. And so the production and impact on healthcare professional and hygiene in healthcare facilities in that area. So just to give you a little bit of background on the design, I'm kind of trying to split this discussion in terms of the audience. I know practitioners as well as those interested on the M&E and the data side. And so I'm trying to talk about both intervention and the evaluation in the same, but happy to answer questions about both at the end. So the intervention is as you see at the bottom, the WHO guide to local production of ABHR. This is a facility-based guide, so it's really recommended for large or national referral hospitals that have the capacity to produce ABHR themselves and the resources and space to do so. What it leaves out, unfortunately, is the ability for smaller facilities to produce for themselves, because in many cases, while they might have the ability to, it's not very hard to produce, they might not have the space or time or resources to do so. And so the district-based production that we piloted in this proof of concept really is about a single healthcare facility that's a larger facility producing for themselves, but also for the district as a whole, and doing a full production and distribution system with monitoring of consumption at the facilities. So this was a collaboration between NGOs, CDC, and the local government. District health officials from the local government collaborated with IRC, the International Water and Sanitation Center, IDI, which is the Infectious Diseases Institute of Makerere University, and then my team at CDC to guide, implement, and evaluate the project. And the local government's role was really to provide space for production and distribution. Their officials performed the external quality control of all ABHR before it was distributed. And then they supported the distribution process and coordinated with health facilities, including having their staff do the monthly evaluation of hand hygiene facilities at each healthcare facility itself. IDI had provided the technical capacity for the production itself. So they hired an ABHR producer and study nurse to coordinate the project, and they procure the raw materials. The local manufacture of ABHR protocol is fairly simple. It's 4 ingredients mixed together, ethanol, hydrogen peroxide, glycerol, and deionized water, as well as other materials needed, plasticware to mix it effectively, and then an alcoholometer to measure the alcohol content at the end. And to talk a little more about the quality control aspect, so once the ABHR is produced or mixed together, the target concentration is 80% alcohol, with acceptable limits between 75 to 85%. An internal quality control is done by the producer right after that initial production, and then that ABHR is quarantined for 3 days at the storage facility, and then external quality control was done by the district health office of the local government before that was distributed to the healthcare facilities. So our evaluation questions were twofold. One, is locally produced ABHR acceptable to healthcare staff and patients in these settings as compared with sort of the standard of hand washing with soap and water? And does it actually improve hand hygiene practices compared with soap and water? Our design was a randomized crossover intervention control healthcare facilities. So what we did is we did a baseline assessment of wash and hand hygiene in these healthcare facilities in August and November 2018. We then randomized the facilities by size, so stratified within the different sizes of facilities to even them out. We assigned them to one of the different groups, and one group got the ABHR that was locally produced. The other one just received soap and water or the normal kind of materials that they already had. We monitored them over a 3-month period. We did a midpoint assessment where we recollected those data, crossed them over, and then monitored them again for 3 months and did an endpoint. And we presented a lot of this actually at a previous UNC conference, but the addition as well now is that we have a final data point 1 year after the production process or the initial study, if you will, was finished. And this was now in November 2020, in the middle of COVID, to sort of see what those hand hygiene, what that hand hygiene adherence looked like. So this was ideal world, and you'll probably guess that since I'm showing you the ideal, there's some changes that happen in the real world. What happened was that in Cabarole District, which neighbors the Democratic Republic of the Congo, there were threats from Ebola happening right as our study was starting. And so UNICEF and others distributed Soraya, which is a commercially produced ABHR to all the healthcare facilities in that district. And of course, this is absolutely necessary and what we want to see in terms of public health. Not so great for your evaluation design. We sort of lost our control group in this case. So our new modified evaluation questions were basically, is local ABHR acceptable to healthcare staff and patients, really as compared with the commercial ABHR? So is it any worse or not? Sort of almost a non-inferiority assessment. And then does locally produced ABHR improve hand hygiene practices? Again, not comparing to soap and water. And we sort of have to limit that. We've effectively lost our control group. So I'm giving you that caveat up front that we had to sort of do a very standard before and after assessment because of the fact that everyone got ABHR in some form, although we were at least able to collect some qualitative data comparing our local to the other commercial. So evaluation methods, we did focus group discussions, observations of hand hygiene before and after patient contact, quality control, and hand washing assessments. Our observations of hand hygiene were focused across the different healthcare facilities, and they really focused on the, or also collected data on the type of healthcare worker and the type of contact. So just to note, in terms of our compliance definition for hand hygiene, we counted that as using ABHR or using soap and water. Donning gloves alone without any other hand hygiene was not considered compliance. So let's get to the observation data. We collected data from initially 15 healthcare facilities, the largest healthcare facilities at baseline, but then did all healthcare facilities in the following evaluation points. And data to focus on. The main data to focus on here is looking at these graphs. You've got the before patient contact on the left, the after patient contact numbers on the right, and the composite, or in the middle rather, and the composite on the right. And what you see in green is ABHR use, and in blue is hand washing with soap and water. I'm also showing you in the dashed lines the donning new gloves without any sort of hand hygiene, just to show you when that was practiced. And so what you can see is at baseline, we had very low composite compliance and low compliance overall, about 3%. That increased to about 43% or so at the first evaluation midpoint. 1 year later, or 1 year after the start of the intervention, that had decreased a little bit to about 24%. And then at that final evaluation point in the middle of COVID in November 2020, we were at about a 44% compliance of hand hygiene overall. Two big things in terms of this, thanks Timothy, two big things to note in terms of this graph are that one, a lot of the hand hygiene being practiced you see is green, so it's actually using ABHR, which is great to see. Two is that there's much more hand hygiene practiced after patient contact than before patient contact. And this multivariable analysis kind of shows similar things. Compared with baseline, we had higher levels of compliance with hand hygiene at midpoint, endpoint, and 1 year follow-up. After patient contact, hand hygiene was about 6 times more likely than before patient contact. Didn't seem to vary by the type of contact that was employed or type of contact being used. And smaller healthcare facilities, so HC3s, were actually more likely to practice hand hygiene. And then lab technicians were less likely than clinical officers to practice hand hygiene, mostly because they were actually donning new gloves without hand hygiene at all, which of course, without ABHR and washing with soap at all, which of course we didn't count. So in terms of strengths and limitations, we did show that locally sourced production of waterless, portable, quick to use hand hygiene was possible, and built capacity for production and distribution of ABHR. However, I would say the distribution model in this study is not as sustainable cost-wise because we essentially paid for the materials and distribution. But as I'm happy to talk about in the question answer, we have expanded this to 6 other districts in Uganda, as well as Kenya and the Central America, and are currently using more sustainable models there. This was sort of meant to be a proof of concept to see whether it could be done. And we're now integrating the production and distribution into the district and national budgets and models there. It's important to note that ABHR is not effective against all pathogens or in all situations, so we have to be judicious about when it's used. And again, hand hygiene before patient contact was much higher, was much lower rather than after patient contact. So there's still a need there. So just in conclusion, the locally produced district-wide production is feasible. ABHR supply in healthcare facilities appeared to improve hand hygiene, but adherence again was much higher after patient contact than before. And we've successfully rolled it out in other locations with more integration into district production, distribution, and monitoring systems to ensure it's sustainable. But that is a continuing work in progress that I'm happy to talk about as we get to the question and answer. Thanks.
Thank you for that, David. And once again, for audience and attendees, feel free to type any questions that you have for David into the chat on Pathable. So Colleen Naughton asks, did the healthcare workers accept locally produced ABHR as much as the commercial product?
That is a great question. In fact, they did overall, and I didn't show the focus group data, but they did like it just as much. And they actually, one of the things they liked about it was that it was locally produced. There was, and we've seen this in the other locations where we've had it. There's actually been a desire by districts to brand their district name on it to show this is produced here. You know, it's produced in Cabarole, produced in Kasese. That's kind of been a point of pride, and it made them feel like it was also more available locally, and therefore they could rely on the supply chain a little more than this nebulous commercial supply chain that they don't know when it's going to be refilled.
Fantastic. That's great to hear that there is that local support and that desire for potentially a locally grown solution. So Colleen also asked a follow-up question of, can you explain why ABHR isn't effective against norovirus and C. diff?
Yeah, I mean, so those and several other bacteria and viruses, and then many of the parasites are just not really inactivated by alcohol in these settings. So in terms of even the healthcare indications that we give and WHO as well, you know, it's really around using ABHR when you know you're not in situations, for example, where you're going to have contact with C. diff or norovirus. So around toileting events and any sort of fecal events, things like that, we still always recommend hand washing with soap and water as the standard, just because of that chance that you've got something that is resistant to alcohol in that case.
Yeah, and Joanne Barlow actually asked kind of a similar question to what you were just answering, or kind of jumping off of that, which is, did the presence of ABHR reduce the likelihood of people washing their hands with soap and water? Kind of, was there any conflict there, or was it paired well?
That's a good question. I would have to go into, so those numbers I presented were just overall compliance numbers and what people used. We didn't, I think in the last assessment, we may have data on what was actually available in that specific location. So I can't say necessarily that in every location, everyone had the same choice of both materials being present. It may be that ABHR was more available because it's a little more portable. And I did note also in the presentation, but I didn't say it, that we started out also trying to provide 60 ml kind of personal bottles for everyone to have on themselves. That was a great idea and is one that we've seen asked for in many settings, but have never been able to actually really implement well and keep. Those were lost within the first 2 months by providers. So something that does make it more portable, but also we haven't successfully been able to kind of recover those at a normal rate where we wouldn't just be buying tons of personal bottles on a regular basis.
Right. And so we have time for one more question from our audience. And I will say to all of our audience members and all to our speakers, feel free to continue asking questions in the chat, even once our presenters are done, and our presenters will be able to respond to this message directly in the chat or in direct messages on the conference platform. So Darcy says, thanks, David. Could you speak to the relative costs of each. So locally produced ABHR, commercial ABHR, soap and water. And then from the more expensive options, are there any added benefits that justify those costs?
Yeah, so I can, I don't offhand on my mind have the numbers for what the costs are for the hand washing with soap and water. I do know the commercial versus the local production was a point that we actually looked at very specifically in this case. So commercially produced ABHR, when it was procured in 2019 for Ebola, the Soraya was about $8 a liter. That actually jumped during COVID, similar to in the US and everywhere else. There were price spikes everywhere, and so that jumped to up to $50 a liter in some cases. The ABHR production for the local production, the cost for materials is about only $4 a liter, so it's about half the price. That doesn't include, of course, the personnel and sort of the startup to get the production unit together. From our recent paper we're putting together, the numbers for that were, I want to say, about $4,000 to set up a production unit, $4,000 to set up a production unit at a facility. Get that main cost is basically getting air conditioning in, because it needs to be in a temperature controlled environment, so you don't hit the flash point of ethanol too quickly or at all. But the cost overall is still, we're pretty confident, about half or a little over half of that of the commercial ABHR. So we do feel like it was pretty cost effective in that area.
Awesome. Thank you for those great answers. You do still have one outstanding question on the Pathwell side, so if you want to answer that afterwards. Sadly, that's all the time we have for David to present today. But now we're going to transition to our second speaker, which is Christine Marie George from Johns Hopkins University. I see that you are sharing your screen. The floor is yours. You have 10 minutes.
Thank you, Timothy. So good morning, good afternoon, good evening to everyone. My name is Christine Marie George, and I'm an associate professor at Johns Hopkins. And it's my pleasure to present on today our prospective cohort study investigating the association between fecal contamination in the environment and child cognitive outcomes in rural Democratic Republic of the Congo. And the study was a collaboration between my research group at Johns Hopkins and Food for the Hungry, and was funded through a grant from USAID. And so the rationale behind our study is that each year, millions of children in low and middle income countries are not meeting their developmental potential. Persistent enteric infections have been associated with malnutrition and poor cognitive outcomes in children. And furthermore, malnutrition is associated with reduced immune function, which then makes children more susceptible to enteric infections. And this leads to the vicious cycle, which I show here, where malnourished children are getting persistent infections that are worsening their nutritional status and making them more susceptible to growth faltering and leading to poor cognitive developmental outcomes. However, despite this evidence, there's very limited literature on WASH-related risk factors for cognitive development in children. Most studies are focusing on risk factors for diarrheal disease and of child growth. And so our objective in conducting the study was to build an evidence base in this area by conducting this prospective cohort study in rural DRC, looking at the association between fecal contamination and the environment and child cognitive outcomes. And so this study is part of our larger REDUCE program, which focuses on developing innovative approaches to reduce exposure to fecal pathogens for young children, with the goal being to promote a healthy gut with less pathogenic microbes, and the ultimate goal, of course, being to improve child health. And so for our goal around intervention development, we have 3 key pillars that we've been following for developing our intervention approaches. And this includes conducting cohort studies to identify risk factors for child morbidity. And then particularly when we identify these novel pathways, we then take a more targeted approach in terms of delivering interventions instead of following traditional approach of water treatment, hand washing with soap, and sanitation. In addition, we conduct qualitative research to identify the contextual, psychosocial, and technological factors that are driving these target wash behaviors. And then finally, we conduct pilot studies to identify the feasibility and the acceptability of the intervention approaches, as well as getting beneficiary feedback and refining the intervention further. And so these pillars together comprise our approach for developing theory-informed, evidence-based WASH interventions. And so for today's presentation, I'll focus on a cohort study we conducted. And so my research group at Hopkins is very interested in developing interventions that target novel fecal exposure pathways. In particular, area of interest of ours is fomites, which are inanimate objects and surfaces that are capable of transmitting microorganisms. And this includes things like soil, a ball a child may play with, or bottles or sticks. And anyone that has young children knows that they're constantly putting things in their mouth. And this is a normal part of child exploratory development. However, in settings with fecal contamination, this can be an exposure route to fecal pathogens. And so our research group is really interested in exploring these further. And so we conducted our study in Eastern DRC in Walungu territory, which is in South Kivu. And you can see here, it's in the red box. And our prospective cohort study included 270 children that were under 5 years of age, which we followed for a period of 6 months. At baseline, we conducted E. coli sampling using the IDEX QuantiTrace system. And this included sampling of soil from child play spaces, objects and surfaces that caregivers reported that children frequently put into their mouths, as well as child and caregiver hand rinse samples, child food samples, and then stored water samples, as well as water sources where households obtain their drinking water. And then at our 6-month follow-up, we conducted a child developmental assessment. And this was done using the Extended Ages and Stages questionnaire, which is an adapted version of the Ages and Stages questionnaire for children in low and middle income countries. And this was recently used in the WASH benefit study. And so the ESAQ, which is the acronym for this tool, combines 5 different cognitive domains. And this includes communication, fine and gross motor function, personal, social, and problem-solving abilities. And so these are combined together into an ESAQ Z-score. And so now I'll go into our laboratory findings. So for the children included in this cohort study, we collected a total of 1,076 hand, soil, surface, object, food, and water samples. And the percentages here are showing the percentage of samples by type that had detectable E. coli. And so we observed that child hand rinse samples were the highest. So 78% of child hand rinse samples had detectable E. coli. This was followed by soil and child's play spaces at 73%, stored household drinking water at 68%, caregiver hand rinse samples at 64%, food at 53%, and then our water sources at 41%, and then objects and surfaces at 36%. And so in this next slide, I showed the concentration of E. coli using a log scale. So the y-axis is a log scale. And we observed that the highest concentration of E. coli was in soil. So this is the soil samples that were collected in child play spaces. And this was followed by child and caregiver hand rinse samples. So next I'm going into our risk factor analysis, where we look to see which of these fecal exposure pathways were significantly associated with adverse cognitive developmental outcomes in children. And so we observed that soil detectable E. coli in the soil and child play spaces was associated with significantly lower combined ESAQ Z-scores at our 6-month follow-up. And we did not observe any other significant associations for the combined score. However, we did observe that child hand rinse samples with detectable E. coli was associated with significantly lower communication ESAQ Z-scores. So to summarize our findings, we found that over half of food, child, and caregiver hand rinse samples, soil, and stored drinking water had detectable E. coli, with the highest levels, again, being in soil samples. We found that children that had E. coli present in their play spaces had significantly lower combined ESAQ-Z scores. And so in conclusion, these findings demonstrate that interventions are needed to reduce fecal contamination in the household environment, as we all know, but in particular that soil is a route that's important and that interventions are needed to reduce child contact with soil to try to improve cognitive development among susceptible pediatric populations in our study setting in rural DRC. And so for the last part of my presentation, I wanted to go back to the REDUCE program objective, which is to develop interventions to reduce fecal exposure, childhood exposure to fecal pathogens. And so for our intervention development, we conducted the cohort studies, which I had just showed an example of, as well as qualitative research, which included 91 in-depth interviews, as well as a pilot study of 102 households. And this led to the development of the reduced intervention module on child mouthing, and in particular, protecting children from the dangers in the dirt. And so this module is delivered through home visits using the care group model, and included a locally sourced play mat, which is actually made out of a rice bag, which you can see here, which is a very low cost option. And most households have rice bags, and so they can sew these together. And the recommendation was to keep young children on these play mats to prevent them from putting dirt in their mouth. And so this intervention would be more effective for younger children that were less mobile. In addition, it was recommended that caregivers stop children if they observed them putting soil in their mouth when they were playing, along with cleaning toys with soap and water. And so the modules that were developed through this theory-informed evidence-based approach are currently being delivered to over 1 million beneficiaries in Eastern DRC. So this child mouthing module, as well as our other reduced modules. And so we're really interested in going and doing follow-up visits, and in particular doing a randomized control trial to be able to evaluate the effectiveness of this intervention approach in terms of child morbidity. So now I would like to acknowledge our team in DRC at Food for the Hungry that worked really hard to implement this project. And this photo here is showing our field research officers that were working in Walungu. And I would like to especially acknowledge Dr. Lucian, who is on the right here, and he led a lot of the intervention and evaluation activities, as well as Dr. Patrick Marundi. And I would like to also acknowledge our investigators at Johns Hopkins, including Elizabeth Thomas, who spent a lot of time developing our formative research. And so Dr. Elizabeth Thomas is a qualitative research expert, as well as Camille Williams, who's our site coordinator for our research program in DRC, as well as Dr. Jamie Perrin, Camille Morgan, Ruth Lee, and Jennifer and Ron, who all contributed greatly to this study. And I would like to also acknowledge our collaborators at Food for the Hungry, including Sarah Baylor and Nicole Congolese, as well as Phil Moyes for their support. So with that, I conclude my presentation, and I would be happy to address any of your questions.
Thank you so much for that, Christine Marie. And so you do already have a lot of questions. So Rick Johnson, our next speaker, says, really interesting analysis. It seems like the cutoff was for one most probable number per 100 mil or per gram. Did you also look for correlations with EASQ at higher levels of contamination, like 10 or 100 most probable number?
We did. So what we did was we looked at the variable using a cutoff of was there detectable E. coli. And we also looked at E. coli as a continuous variable and log transformed that. And our child, the soil being present in child play spaces was associated with our ESAQ, both as a cutoff of 1 E. coli per gram of soil, as well as a continuous variable. So E. coli in soil was significantly associated with poor ESAQ outcomes, both as a cutoff and as a continuous variable.
Great, thank you for that. And so Colleen asks, is there any connection with food insecurity, since if children lack nutrients like iron, they try to eat dirt?
So we haven't explored that directly, but that's definitely potentially associated. And as part of our mouthing module of soil, we actually had one section where we discouraged pregnant women from consuming soil. And so that was something that came out through our qualitative work, that it was important for us to include that. And that's, as I'm sure you know, is likely related to micronutrient deficiency during pregnancy. So it's likely that that is potentially possible for young children as well.
Great, and so Julia asks, why do you think that only soil contamination was associated with worse cognitive scores and not the other pathways of fecal exposure?
So we were really surprised about that. And as I mentioned, the child hand-rinse samples were also associated with the cognitive ESAQ, but not the combined one. We think that potentially with a larger sample size, we would see more significant associations, given that the trends were in the correct direction for a lot of these fecal exposure pathways. So based on our findings, we think soil maybe is the largest contributor, but other routes are probably likely important as well.
Definitely a great opportunity for additional work in that space. So we have time for one more question. And once again, if attendees want to continue posting questions in the chat, Christine Marie will be able to answer after her presentation is concluded. So Frederica says, did you collect any data on the presence of animals at the time of visits? And if so, was that having any influence on the results?
So we did look at that, and we didn't see a significant association between animals being present and our child cognitive outcomes. But I recommend that other researchers that have the same type of data set look at these associations also, because it's important to understand risk factors, wash-related risk factors for child developmental outcomes.
Great. And so you actually have a couple, 3 or 4 more questions for you waiting in the chat if you want to answer those. Sadly, that's all the time that we have for Christine Marie. Thank you again for your presentation and the great work. We're going to transition now to our final speaker, Rick Johnson, who is the co-leader of the WHO UNICEF Joint Monitoring Program.
Thank you.
So, yep, absolutely. And so, Rick, I see that you were able to share your screen. The floor is yours. You have about 10 minutes.
Thanks so much, Timothy. So hi, I'm Rick Johnston from WHO, and I'm presenting today on behalf of the WHO UNICEF Joint Monitoring Program, as well as additional UNICEF colleagues involved in this work, Esther Shaler and Rob Bain. Now, both WHO and UNICEF procure portable water quality testing equipment for government partners, and we wanted to have a rigorous assessment, both of the equipment that we're currently using, as well as any existing alternatives or new innovative products that might also be suitable for testing water quality in the field without needing electricity or highly trained technicians. Let's see. And I'm really happy to be finally sharing some results with you at UNC. 2 years ago, we had a poster up describing the ongoing work, which actually began even before 2019, with a review of laboratory assessment protocols. So it's been a long time coming. That led to the development of a protocol to test portable testing kits. And after finalizing that with our technical advisory group, we made a public call for a laboratory to conduct the work and ended up selecting the KWR Research Institute in the Netherlands for that. We then selected kits for the assessment, and all of these are based on incubation of some fecal indicator bacteria, and those could be based on suspensions or colony counting methods. The KWR lab then made 2 phases of assessment, a first screening phase using pure lab E. coli over a wide range of concentrations. And then some of the kits were then selected for more in-depth assessment using wild E. coli and natural waters, looking for false positive or negatives in the presence of non-target organisms, and in some cases looking at extended temperature ranges if the manufacturer claimed those as possible. So we ended up selecting 20 portable test kits to assess, and 10 of these were based on counting colonies. Most of those used membrane filtration, but one used a gel medium. We then found another 10 kits based on suspensions, which would change color or in some cases fluoresce in the presence of E. coli. And 6 of these were designed to give presence-absence results in a 100 milliliter volume. And we converted those into a quantitative measure using 96 well plates so that we could calculate a most probable number, an MPN. And 4 of the kits had their own, 4 of the kits had their own proprietary MPN method involving wells in a tray or compartments in a bag or some other way to quantify E. coli in suspension. And the MPN methods give both a point estimate and 95% confidence intervals around that estimate. Most of the technologies were available off the shelf, but 5 of them we considered as novel. They were either still under development or recently developed. And some of those were identified through UNICEF Supply Division's innovation program, which Esther could happily tell you more about. So on to results. In the first screening phase, we used pure E. coli in lab water under controlled conditions, and all the samples were done in triplicate. We found that often trial methods would give lower results than the reference method, which was ColAlert Quantitrade, just like Christine was using in DRC. We also found that membrane filtration often gave lower results than suspension methods. And finally, some of the novel products were still really under development and had quality control products. So on the basis of these results, we took 14 of the kits into the phase 2 testing, leaving out 2 novel products, which were 2 commercial suspension media and 2 commercial plates. Here's just a picture of what the results look like. We had 6 dilutions, 4-fold each, conducted in triplicate. And we wanted to go from above the detection limit, the maximum quantification limit, to below the detection limit. So on the left, you can see the results for one of the novel media, Resirufin. It's the pink stuff that was on my cover slide. It turns pink in the presence of E. coli. That went up to around 200 CFU or MPN because the more concentrated stocks yielded all positive wells with the trial method, so it's unquantifiable. The upper limit of quantification was about 440 MPN per 100 mils. And with Resirufin, the agreement with the reference method was excellent. We found, oh gosh, my slides keep advancing themselves, sorry. So we found a slope of about 1 and high correlation measured with Pearson's and Spearman's R. But on the right, the aquachrome ECC method did have quantifiable results for the higher concentrated stocks, which the reference method found to have about 800 MPN, but aquachrome found more like 300. So even if you exclude that stock, there was a negative bias across the concentration series with an overall recovery of about 35% compared to the reference method. So we ended up looking at Resirufin, but not aquachrome in the second phase of analysis. So in that second phase, then, we looked at 14 kits evenly split between colony counting and suspension methods, and including 3 of the novel methods. We don't have any pass-fail criteria here. We're just reporting the results of the different challenges, which included how well does the kit do in the presence of non-target bacteria, either false positive or negatives. If the manufacturer claims that the kits can work at different temperatures or incubation times, how well does that work? And maybe most interesting, how do the kits do in different natural waters using wild E. coli instead of a lab strain? Well, we didn't find any serious problems with the non-target bacteria. A few products did have low-level positives with Aeromonas or Pseudomonas, or have reduced recovery of E. coli when there were also a lot of other non-target bacteria in the water. And as you might expect, we found slower growth and lower recovery at lower incubation temperatures. And for some products, inhibition at very high temperatures, 45 degrees. So we also looked at these 5 natural waters, 2 surface water, 3 groundwaters. We sterilized those and spiked them with diluted wastewater effluent. We were aiming for around 300 CFU per 100 mils, at which we would then serially dilute tenfold 3 times. So we would get high, medium, and low concentrations. And again, everything done in triplicate. Here we found higher recovery and better agreement with the reference method than we had with pure E. coli, which was nice to see. There were a few trial methods that had higher counts than the reference method. 2 of the kits measured thermotolerant coliforms, so that's not surprising. But one of the selective media and one novel method were meant to be specific to E. coli, but perhaps weren't all that selective. One interesting finding is that there was excellent correlation in phase 2 over all water types between the hydrogen sulfide kit in a MPN format with the reference E. coli method. So what we did is we took the H2S media and put it in those 96 well plates to get MPN. But we know that the positive H2S results are not due to E. coli because pure E. coli doesn't reduce sulfate. And we confirmed that in phase 1, where we used Citrobacter instead of E. coli for screening the H2S media. So it's a classic correlation and not causation, but it does suggest that the H2S kit could have more value as a quantitative test, and that the quantification of fecal risk is very similar to that you see with E. coli. Of course, there are concerns with H2S about false positives, but we didn't find any evidence of that either in phase 1 or phase 2. So here's an example of the results from one of the novel technologies that was assessed. We used 2 surface waters and 3 groundwaters that are shown in the different columns with different colors. And they were spiked on different days with wastewater effluent to give those high, medium, and low levels of contamination. And you can see that across all of the different waters and all of the contamination levels, this trial method matched the reference method quite well. There might be slightly lower recovery compared to the reference, but there was good linearity and reproducibility, and nearly all of the samples were in the same risk class as with the reference method. So this is my last slide. That's all for now, well, except for acknowledgements, don't forget that. But our next steps are to discuss with the manufacturers and to publish the results, both as reports and hopefully as a journal publication. The main finding does seem to be that there are a number of portable tests out there available for E. coli testing in the field, which performed well with respect to reference methods, though some do have limitations under certain conditions. Also, several manufacturers are working to develop more innovative or novel products that are rapid or easier or less expensive. And some of the novel products that we did test show promise but need further development. So we'd like to do an additional round of testing, focusing more on those novel products and possibly to look at chemical or physicochemical test kits as well. Finally, I would just like to thank the whole team at the KWR Water Research Institute. I think Anke Brouwer's on the call today. Ronald and Gertchen were fantastic to work with. Also, UNICEF Supply Division, who helped identify and procure the kits, and the technical advisory group to the project. And last but not least, this work was made possible because of the financial support from the Dutch government through DGIS. Thanks. Timothy, would you facilitate any questions and answers? I'm not sure if we have any. I haven't been keeping an eye on the Pathable chat.
Yes, sorry, my apologies. My Wi-Fi just cut out, but we're back. So thank you for that great presentation. And yeah, we'll transition over to Q&A. Okay, so Colleen asks, and for anyone who hasn't seen already in the chat, Esther did post the link to get more context on this project and some more readings about it. So Colleen asks, which kit would you recommend the most at this time, if you're able to make that recommendation?
Okay, well, Colleen, the manufacturers haven't even seen the results yet. So the first thing is to talk with the manufacturers. So I wouldn't say anything without going through that first. But I will say that we put the equipment that the JMP has been using to support water quality testing and household surveys through the assessment. And that's a commercial off-the-shelf materials, and they did quite well in the assessment, thank goodness. So we're happy to keep on using those that kit, though there were a couple of products that we might consider that that gave comparable or even better matches to the reference method.
Great. Yeah, I imagine that making recommendations this early may be difficult. So Adele asks or says, very interesting, which I definitely agree with. When do you anticipate that the reports will be ready and when you can start making those kind of announcements?
So all the testing has been done. So really it's a matter of how long it takes us to write up the results. I expect we'll publish technical reports on the WHO website probably before we get to putting together a journal article, but maybe aim for that sometime next year.
Great, we'll definitely be looking forward to that. And so to all of our audience members, you can definitely continue posting questions. So one question that I have is that in this, how do you, when you're selecting your frame of reference or your kind of kit that you're testing against, how is it that y'all have gone through selecting, because I think you said that you use call alert, not membrane filtration. And so I was wondering if you could just talk really quickly on why call alert was selected. Was that correct?
Oh, you mean as a reference method? Yeah, I mean, so to make the assessment, we had to select a kind of gold standard reference method. So we looked at the methods that are approved, by different regulatory authorities, and the call alert quantitray is approved by US EPA. It's also widely used in Europe. So it was just an easy and recognized as high quality reference method to use. In terms of which kits we identified, again, the UNICEF supply division had some things already on catalog, and then they have this innovation program to see if there might be things that can really turn around results more rapidly or cheaper or easier. So we identified some products through that channel as well.
Great, thank you. So we have a few more questions. We have time for about 2 more questions. So Colleen asked another question, which is, are there plans to test other kits for other pathogens?
Sure. Well, this is interesting because we didn't actually test for pathogens. We tested for fecal indicator bacteria, but some of the novel kits don't measure E. coli or thermotolerant coliforms. They measure pathogens directly. So one reason we wanted to do the E. coli tests first was to get the methods well developed, because it's not clear how you can assess something that purports to measure pathogens directly. E. coli is an imperfect indicator. So, is your question, Timothy, about what reference method to use is particularly challenging if we look at some of the nucleic acid methods. So I think for now, we'll probably end up referencing E. coli as the WHO recommended indicator of fecal contamination, but we'll recognize that if something is really saying that it measures pathogens directly, there might not be a perfect correlation with E. coli. Right.
Yep, and that's what I was expecting with the complexity of those tests and what you use as that reference. So last question that we have time for, Drew asked, will the report offer any guidance about supply chains, given that sometimes it's easier to import one type of kit into some countries compared to others?
So actually, this links to a discussion we were having in the session right before this, where UNICEF and WHO and the UNC Water Institute are working to produce some guidance around selection of field testing kits. So a lot of those criteria about supply, about supply chains, imports, ease of use, costs will be explored or will be addressed, I would say, in that document that's under preparation. Again, I think that'll the target is to come up with some publications on that next year. But in the meantime, you could go back and look at the recording for the session just prior to this one.
Great, thank you. You provided a great transition for me. And so sadly, that's all the time we have for Rick Johnson. We'd like to thank you again. And we'd like to thank all of our presenters for some great presentations. Lastly, to close out, one second. So to close out, we just have a few closing announcements for everyone. So once again, we do have the poster sessions that will be happening this afternoon in about 15 minutes or 20 minutes, my apologies. And so you can check those out, drop in and be able to talk or to ask questions directly to our poster presenters. Additionally, we'd like to remind you that once again, we have a networking event with Remo at 3:30 p.m. today. We also have the late early show tomorrow morning at 3 a.m. Eastern time, where we'll be talking about the lessons learned from the plenaries today and how we can use those in Africa. And then lastly, we want to thank our sponsors for today's session, so BioRad and Reckitt Global Hygiene Institute. That is all the time that we have for today's session. Once again, we'd like to thank everyone for joining, and we hope that you have a great day and a great rest of your time at the conference. Thanks all. I remind you that if there are any outstanding questions, feel free to answer those in the chat over the coming days. And hopefully we'll have our the recording up this evening if all things go well on the technical side.
Thank you
again
so
for
much, Timothy. You did a great job. Thank you so much.
It was entertaining. My internet was the one that cut out today. So thank you for
And Rick, I
being
really
flexible
enjoyed
and
your
being-
presentation. And David, I enjoyed your presentation also.
Likewise, it was a great session. Wish we were all together and we could go have a coffee and talk about it all, but still, this was quite nice. Thanks, everyone.
All right, bye.
Thanks, y'all. I'll be closing the room now for